Good evening and welcome to tonight's Immunisation Coalition webinar event. Our topic this evening is exploring herpes zoster, shingles in Australia. My name's Susie Blackburn. I'll be your moderator this evening. I'm the event manager at the Immunisation Coalition. Firstly, I'd like to acknowledge the traditional custodians of the various lands on which we work today and the Aboriginal and Torres Strait Islander people participating in this webinar. I pay my respects to all First Nations communities and celebrate the diversity of Aboriginal peoples and their ongoing cultures and connections to the lands and waters of Australia. Presenting tonight's session is Angela Newbound, who will be speaking for around 40 minutes. This should leave us plenty of time to answer questions or comments you may have. Regarding that, please make sure you type your questions into the Q&A box, not the chat box, anytime during the session. Angela and I will have a chat during the session, and sometimes the questions will be asked throughout the presentation. Tonight's presentation will be recorded, so all participants will be automatically on mute for the event. Angela Newbound is an immunisation education consultant based in South Australia and also a member of the Immunisation Coalition. She's been involved in immunisation program delivery for over 20 years as an immunisation provider, program coordinator with roles within the Division of General Practice, South Australian Health and the Medicare Local Network. Presently, she's with the Primary Health Network. Thank you so much for joining us once again, Angela, for our final webinar of the series of 2022.
Thank you very, very much, Susie, for that introduction, and certainly thank you to the Immunisation Coalition for inviting me to present the webinar tonight. It's a real honour. I'd actually like to also acknowledge I'm coming to you from Adelaide on the traditional lands of the Kaurna people, and I pay my respects to Kaurna elders, past, present and emerging, and I also pay my respects to all First Nations people from other regions and certainly thank them for sharing this beautiful land with us. So we're going to have a little chat around herpes zoster. I think you would probably all know this very, very well, so we won't labour too much, but we do know obviously that after that initial infection from chickenpox, this virus will hide in our immune system, in our dorsal root ganglia for the rest of our lives. We don't know why, but certainly sometimes this virus will wake up, if you like, and travels along nerve fibres that will reach down to your skin, and obviously this becomes shingles. It certainly is linked to, that decline in cell-mediated immunity. So, when people are a little bit run down, as we age, we have a decline in cell-mediated immunity. People that are recovering from other viral illnesses potentially, and we're seeing a little bit of a rise with zoster post-COVID infection. So COVID is certainly knocking the immune system around a little bit. But there are some, risk factors that we do take into account, and that's increasing age, like I said. And unfortunately for us ladies, we have a slightly higher risk than what the gentlemen do. A little bit of a family history also comes into play, and, we certainly know that those clinical characteristics of shingles will certainly depend on the location of the lesions. We certainly know that this reactivation occurs because of a ganglionitis, and therefore, follow the nerve pathway that's affected will be along a dermatome. So there's no cure for shingles as we know it. And care for somebody with shingles can be really quite complex, requiring medication and sometimes some topical treatments for the blistered areas. But we'll talk about antivirals and pain management a little bit later on in the presentation. And we do know that some people can get shingles more than once. But generally, most people won't have recurrent shingles, but it certainly does happen, that's for sure. So we know, like I said, this is a a latent varicella zoster virus that migrates along that sensory nerve, reaches the skin. Because it follows a dermatome, then generally we will see lesions only on one side of the body. It's very, very uncommon that we will see this shingles rash affect both sides of the body. It's usually unilateral. So that's probably a little bit of a trigger if you are looking to see whether or not it might or might not be shingles, or is it another type of a rash, a viral illness rash, or measles, or whatever it is that you might be looking at. Certainly, you know, just think about the location. Is it along a dermatome? Is it unilateral? So we've established that. You know, it is a very, you know, herpes zoster or varicella zoster virus is very infectious, obviously, and 90% of those who have never had chickenpox or, you know, were not vaccinated are most likely going to become infected if they did come into contact with somebody that either has chickenpox, or if they've come into contact with the blisters from somebody that perhaps has shingles. So transmission is via direct contact. It is from that, the fluid in the blisters. You could definitely contract it by, you know, touching soiled articles of clothing or bedding, particularly if, you know, some of that fluid has leaked on. So it is less contagious though than from the blister, you know, the fluid in the blisters, than chickenpox itself. But we do encourage anybody that does have a shingles rash that they do cover the rash with a light dressing, just to reduce the likelihood that someone will come into contact with the fluid from those blisters. So once a person blisters have sort of crusted over and they don't contain fluid anymore, then the person is considered not to be infectious. So people with active herpes zoster lesions, like I said, should really cover them just to reduce that you know, possibility of contact with other susceptible people, either in the household or perhaps in an occupational setting. And we definitely want to sort of protect our vulnerable people in the community, and definitely pregnant women and people who are immune compromised, for sure.
Now, Angela, I might jump in if I can and just answer
Yes.
one of the questions. Someone would just like to clarify that if you get shingles when you're older, it means that you've had chickenpox when you were younger, but may not have known it. Would that be correct?
Oh, absolutely. Chickenpox actually can be asymptomatic. So not everyone's going to get sick, and with any disease, people can be asymptomatic but still actually have the disease, and we're seeing that obviously with COVID as well, but we see it with chickenpox. The other thing with chickenpox too is it depends on whether it was diagnosed or not diagnosed and how it was diagnosed. Some people have just had 3 spots and the parents just said, oh, he's been bitten by mozzies, but it actually might have been that child's chickenpox exposure. So no, you don't need to get lots of lesions, you don't need to be really sick. That's nothing right. Like that. Yeah,
thanks for that clarity.
You've had chickenpox, even a few spots. Yeah. So in regards to symptoms, the presentation and of zoster may not always be that straightforward. 80% of cases will have a what we call a prodromal phase, so around about that 2 to 3 day period before the rash appears, and there are things like headaches and photophobia and just feeling a bit flat and a bit run down, and they might have a little bit of itching in a certain area or a little bit of a tingling sensation, but they may not. So it's really a little bit ambiguous, really. So quite often shingles is not diagnosed until a rash actually appears. And usually most people will experience some pain around that rash. It will be very uncomfortable for them generally. So until that rash appears, it is really likely that shingles isn't going to be diagnosed. And certainly the differential diagnosis really at that stage is going to vary quite widely and depend on the site and the nature of the pain. And we have seen definitely, and certainly some of you that are listening tonight may well have seen patients present, you know, perhaps with some severe thoracic pain, for example, and you know, everybody's minds have been led off to it being cardiac pain or pleural pain. We've even had patients, you know, with a bit of, you know, sort of left or right-sided back pain, and it's sort of been linked to perhaps you've got renal colic. So it can actually be quite mistakenly misdiagnosed. So unlike chickenpox, like I said, the rash is quite distinctly in an area, whereas chickenpox is really randomly distributed from head to toe, front to back, all over the person. But the common sites affected really are the thoracic dermatomes, and more than half of shingles cases are within the thoracic dermatomes. After that, the most common is actually the cranial nerves. Now, this can cause, obviously, problems with eyes. So we'll talk about these complications a little bit later. And then followed by lumbar pain. People may have it around their neck or perhaps down in their sacral area. So in regards to those cranial nerves, so about 13% of ZOSTER cases occur with those cranial nerves, and it's the trigeminal and facial nerves which are the ones that are most likely going to be affected. So sometimes there's dermatomal pain, but there's no rash, and that's called ZOSTER sine herpes. So it's a rare form of shingles that occurs without the rash, and diagnosis is obviously much more challenging because there's pain, terrible pain, but there's no rash. So that's very, very easily to be confused with those cardiac or pulmonary or renal problems that we might be suspecting. So what about a rash and no pain? And so a patient that presents with a rash but no pain is probably less likely to have shingles, although it can occur rarely, and probably more likely to be in young children. So definitely it's worthwhile, if there's a rash there, just think about where is the rash? Does it look as though it's along a dermatome? If there's no rash there, certainly think about shingles, see if there is decreased or changed sensation in that particular area where the person is reporting pain. If there's change in sensory, if there's sensory changes, should I say, then definitely start thinking that this certainly could be shingles. So the most common complication of shingles is this persistent chronic neuropathic pain, and it's called post-herpetic neuralgia or PHN. And there's no real international consensus on the definition of PHN, but most experts will agree that true chronic neuropathic pain is pain that persists beyond 90 days from the onset of the rash. So there are some additional risk factors for PHN. Definitely the presence of prodromal pain, greater acute pain, greater severity of the rash, and greater degree of sensory impairment in the affected dermatome. So the more severe the ZOSTER case is, the higher the risk of PHN. So PHN will quite often present as a real throbbing or aching, stabbing, burning, tingling type pain. And there's certainly a condition called allodynia which is pain due to a stimulus that doesn't normally provoke pain, such as the wind blowing on somebody's face being exceptionally painful, just running a hairbrush or a comb through their hair, wearing any clothing laying on top of them is excruciatingly painful. And then, of course, there's dysesthesia, which is a sensation people will often describe as painful, itchy, burning, and really restrictive. For the gentlemen out there, it's actually thought that acute ZOSTER is considered to be more painful than labour pains. So from someone who had a caesarean section, don't know about the labour pain thing, but as a midwife, seen plenty of it. So very, very painful. And PHN pain has been described as being more severe than osteoarthritis and rheumatoid pain. So post-hepatic neuralgia, very, very difficult to manage. There's usually treatment with analgesics, neuroleptics, other drugs that may be needed for months, if not even years. So definitely we want to reduce the likelihood people will get shingles in the first instance to reduce the likelihood that they'll get post-hepatic neuralgia. So we talked about these complications that might occur, and Tony Cunningham and his colleagues wrote an article that was recently published in the Medical Journal of Australia in regards to the complications of shingles, and they kind of grouped it into 4 major groups. And we've got, issues cutaneous. So they're bacterial superinfections of the skin lesions caused mostly by Staphylococcus and causing a cellulitis. We've got neurologic areas as well, meningoencephalitis, aseptic meningitis, cranial nerve palsies, and peripheral nerve palsies. We've got ophthalmic complications, so conjunctivitis, episcleritis or scleritis, keratitis, secondary glaucoma, and acute retinal necrosis. And we've also got the complication of being disseminated disease, and the symptoms are obviously much more severe, dissemination occurring 1 or 2 weeks after the initial symptom of herpes zoster. So these, obviously anyone with disseminated zoster would be hospitalised, they need an intravenous antiviral therapy, and they are very, very sick patients. Obviously, people who are immune compromised or they've got a suppressed immune system in any way are more likely to have complications from herpes zoster. They are more likely to have a severe, long-lasting rash and more likely going to develop disseminated herpes zoster, although it's still rare. Recent data has also shown that having shingles also increases the risk of a stroke. And this tends to be because these types of inflammatory infections cause plaque destabilization in arteries. So if someone has plaque in their arteries, it's destabilized, it starts to fall off the arterial wall. Our little clotting cells will come, think that we've got an injury, so they will make a nice little clot around that. But then that piece of plaque will continue to fall off. And once it falls off the wall, then technically we have a clot floating around. And there is really quite significant evidence of stroke following shingles for that reason. So according to the NCIRS, the National Centre for Immunisation Research and Surveillance fact sheet, about 20 to 30% of people will have shingles in their lifetime. So around, about a third of us, and most of us after the age of 50 years. Older people, particularly those over 70 years of age, are more likely to have shingles complicated by post-hepatic neuralgia. So advanced age is definitely associated with more complications. Immune compromised people, like I said, have higher rates of complications than immune competent people, and comorbidities also are associated with higher rates of complications. So your lifetime risk, of reactivation of your varicella zoster virus is about 50%, and it will affect about half of people who live to 80 years of age. So we know there is a lot of shingles around, and I'm sure that you are all seeing it. We know that there's about 120,000, 150,000 new cases each year, but we also know that that is underreported. Even though it is a reportable disease, a lot of people may not go to a GP, particularly if it's only a small rash. They will just let it go. It gets better by itself. It was a bit painful, but they'll shrug it off. So, like I said, the rate of shingles will rise with age. And if you are a stats person, how much does it rise? So we can go from 6.5 cases per 1,000 population in persons aged 50 to 59 years, and that rises to over 14 per 1,000 population in those individuals over 70 years of age. So that's a reasonably significant increase. So if we look at burden of disease, this is a nice little graph that's as recent as we can get it. This was sourced on the 17th of March 2022, so this year, from the Australian Institute of Health and Welfare Infectious and Communicable Diseases report. So certainly varicella zoster infection, so that's chickenpox and shingles combined, was listed as one of the 4 diseases that accounted for 89% of notifications to Australian health authorities in 2021. On top of was, of course, COVID-19, with almost at that stage 471,000 notifications. Second was chlamydia. Third was Campylobacter, and the fourth was varicella zoster, and where there were more than 33,000 notifications. So this particular graph just shows the shingles notifications. So good news is we can reduce our likelihood of getting shingles, and certainly prevention is always better than the cure. So there are 2 ZOSTAVAX vaccines registered in Australia. One is called ZOSTAVAX and one is called Shingrix. ZOSTAVAX is a live attenuated zoster vaccine. So for those of you that aren't familiar with these vaccines, it's about 14 times more potent than the chickenpox vaccine that we give to the children in the children's program. So it's attenuated, so it is weakened, so it should not cause zoster disease in people who are receiving the vaccine if they are immune competent. But if they are moderately or severely immune compromised, then it can certainly be quite a significant risk of the individual developing shingles and definitely disseminated zoster. And there have been 3 deaths post-ZOSTAVAX in severely immune compromised patients where ZOSTAVAX was actually contraindicated. 2 of those deaths were here in Australia and 1 was in the UK. So please make sure that you've done your risk assessment before giving ZOSTAVAX to anyone. Shingrix is a non-live virus vaccine. It's made from just a single protein known as glycoprotein E, and that comes from the outer shell of the herpes zoster virus. The vaccine contains an adjuvant which is there to boost the immune response. Both of the vaccines do require reconstitution, and after reconstitution, Shingrix vaccine should be used promptly. And if that's not possible, the vaccine can actually be stored in the refrigerator between 2 to 8 degrees. But if it's not used within 6 hours, it really should be discarded. Whereas after reconstitution of ZOSTAVAX, the vaccine, once again, any reconstituted vaccine should be used promptly. But if it isn't, then it's only really got a lifespan of about 30 minutes. If it's not used in that time frame, the vaccine should be discarded. So with your Shingrix, it is an expensive vaccine. I have received my 2 doses of Shingrix vaccine. I paid $283 per dose because it's a 2-dose course. However, I did claim it back on my private health insurance and I got $200 per dose back in my bank account, which I thought was fantastic. So yes, it's an expensive vaccine, but certainly talk to people about options for private health rebates if they have private health. So who should be vaccinated? So ZOSTAVAX is not routinely recommended for adults aged 50 to 59 years. However, ZOSTAVAX and Shingrix are both TGA approved and are registered for the following indications. And one is the prevention of herpes zoster or shingles and post-herpetic neuralgia in individuals 50 years of age and older. But it's recommended for adults 60 years of age and older. So what happens if a person is aged 50 to 59 who wants to have a vaccine? Well, they could have one. But given the incidence of herpes zoster and herpes zoster related complications increases with age, and the duration of this longer term protection of these vaccines is a little uncertain, decision making really at both at the individual level really needs to be taken into consideration. There is some fairly late, very just released data around Shingrix vaccine. So certainly have a little talk to your GSK representatives about that. But we just don't want to vaccinate people too early. At the moment, as we know, there are no booster doses anywhere in the world that are being recommended for these vaccines. So if we do vaccinate someone at 50 years of age, do we or do we not need to be giving them boosters down the track? And we don't know that yet. You know, we don't have a crystal ball. So we do need to have a little bit of a think about it. Shingrix is registered for use in immunocompromised individuals at 18 years of age and older, if they are considered to be at increased risk of herpes zoster. So obviously, refer to the ATAGI, the Australian Technical Advisory Group on Immunisation statement on the use of zoster vaccines in older adults. Both of these vaccines have very good efficacy in preventing herpes zoster, but they have not been compared in any head-to-head clinical trials. So please be really clear on that. We can't compare one vaccine's performance against another because they've not been compared together. So we know that ZOSTAVAX vaccine is the vaccine that's funded under the NIP for individuals at 70 years of age. There is currently a catch-up program for the 71 to 79-year-olds, and that will end in October next year. So please think about recalling any of your patients that are in that eligible group, because we don't want them missing out on this free vaccine. A ZOSTAVAX vaccine, if they do miss their funded dose and they need to buy it down the track, it's probably going to set them back around about $220 for the single dose that's required. So vaccine efficacy is not really affected when administered to people with comorbidities. And so just remember, if any of these people that, splenectomy, diabetes, rheumatoid arthritis, etc., that are on this list are also immune compromised, ZOSTAVAX might be contraindicated and Shingrix may be the appropriate vaccine. ZOSTAVAX can be given to patients with mild immune compromise, where Shingrix is not accessible. So they are the words from ATAGI. So Shingrix is the preferred vaccine for individuals, but ZOSTAVAX certainly can be used in the majority of cases. So do that careful assessment, looking for immune compromise. There is a specific checklist for you to use prior to administering ZOSTAVAX vaccine, and that's called the live shingles vaccine ZOSTAVAX screening for contraindications tool. So definitely use that. It's in the immunisation handbook. So ZOSTAVAX is contraindicated in people who have had obviously an anaphylactic reaction to a prior dose of Shingrix, or to any component of Shingrix vaccine, and exactly the same for ZOSTAVAX. It's contraindicated in pregnant women and in patients with, obviously current and severe immune compromising conditions, and that, of course, is your ZOSTAVAX that's contraindicated. So, as I said before, very rarely disseminated zoster virus infection with the vaccine can occur. So we definitely want to know that we're giving this vaccine to immune competent individuals. So Shingrix really is your only option for the prevention of herpes zoster and its complications in those immune compromised individuals. There isn't any data on the use of Shingrix really in pregnant women. The product information lists the vaccine as a category B2 drug, which is a drug which has been administered to only a really limited number of pregnant women of childbearing age. The data does say that it was administered without an increase in the frequency of malformation or other direct or indirect harmful effects on the human fetus. Certainly haven't been observed. Studies in animals are inadequate or may be lacking, but available data shows no evidence of an increased occurrence of fetal damage. So at the moment, it's listed as a category B2 drug, but being an inactivated vaccine, that may well change as data emerges. Okay, really important, do that full history check. We look at the age-related risk of herpes zoster and its complications. We know that it rises as we get older. The duration of protection needs to come into play. How long will these vaccines protect us? So at the moment, we're looking at that 4 to 10 years. There's a little bit of waning effectiveness with ZOSTAVAX, the live virus vaccine, in that 5 to 10 year post-vaccination period. So we just need to be really conscious about that. We need to be looking at people's immune status. Are they immune compromised? Are they going to become immune compromised? Some younger immune compromised people may still be healthier than a healthy elderly person. So there's no real hard and fast with mild immune compromise or people that are younger. So a really thorough assessment needs to be done. Then, of course, you've got personal choice around this. If a patient wants to come in, they want to be protected from herpes zoster, and they don't want to get PHN, they may be much more literate around one vaccine versus another, and they would need to be guided really by your clinical expertise. But certainly look on the AIR, the Australian Immunisation Register, before you give any doses of zoster vaccines to see whether people have had these vaccines previously, because we can't rely on patients' memories. So when we talk about these immunosuppressive therapies that you need to consider, this list is in the immunisation handbook and also on the NCIRS fact sheets. They've got tables available as well. So it's a good idea to either have these printed off or have them somewhere that you can use very, very readily. So, you know, those high dose corticosteroids, you've got your DMARDs, etc. You know, if you've had a patient with, you know, hematopoietic stem cell transplant, you need to be considering about those, you know, T-cell inhibitors. And then it goes, oh yes, and they're on the same page. So, and then those, you know, chemotherapy, radiotherapies, etc., monoclonal antibody therapy. So vaccination with you know, these shingles vaccines is not straightforward, and this is much more pertinent, obviously, to the live virus vaccine than it is to Shingrix. So there is really good news for, obviously, for those people who are unable to receive ZOSTAVAX due to immune compromise. So certainly speak to your GSK rep around Shingrix, get some resources from them, so you can have those robust discussions with patients. It is not PBS listed. It is full cost. There is no government funding towards Shingrix at all. So if somebody is eligible for ZOSTAVAX because they are 70 or they're in the catch-up program, 71 to 79, but ZOSTAVAX is contraindicated in them because of immune compromise, unfortunately, if they want protection from shingles, then they will have to buy the Shingrix vaccine. So what's the vaccine effectiveness? Let's just have a little look at ZOSTAVAX, and just bearing in mind, once again, there's no head-to-head comparisons of Shingrix and ZOSTAVAX to date. So we're looking at these shingles prevention studies, randomised, double-blind, placebo-controlled studies, and conducted in, you know, sort of 38,500 individuals that were aged 60 years and over. So it's quite a significant study. And patients were randomised to receive either the vaccine or a placebo, and then they were followed up for around about, you know, just over 3 years. They had all had a history of having varicella. They all resided in the United States. And certainly the primary endpoint was the burden of illness due to herpes zoster, a measure affected by the incidence, severity and duration of the associated pain and discomfort. So compared with to placebo, obviously vaccination with ZOSTAVAX significantly reduced the incidence of shingles by around about 51%, but it also reduced the incidence of post-herpetic neuralgia by about 67% versus the patients that received the placebo. So the great benefit really for ZOSTAVAX is that reduction of risk of somebody developing post-herpetic neuralgia. So the shingles prevention study indicated that the vaccine was safe, that it was effective in reducing zoster disease as well as post-herpetic neuralgia. So we can't ask for too much more than that. The fact that it's safe and effective is good news. So if we look at this particular data, you can see here overall vaccine effectiveness was around about that 49% against herpes zoster. And this was sort of really done in a real life setting, really large retrospective cohort study in the United States. You know, there was over 176,000 individuals that were included. And certainly the study showed that in a community setting of routine clinical practice, vaccination was definitely associated with reasonable vaccine effectiveness of around 49% against herpes zoster. If we look at this particular piece of information, it looked at how ZOSTAVAX performed in people with chronic health conditions. And we can definitely see that it was successful. People with these medical conditions were protected from disease. So if we look at Shingrix and the data that we've got here, we know that this is a subunit vaccine. It's given as the 2 doses intramuscularly, 2 to 6 months apart. The efficacy and the safety of Shingrix was tested in 2 really large randomised placebo-controlled phase 3 trials, and they were the ZOE 50 and the ZOE 70 studies. So the ZOE 50 was in individuals over 50 years of age, and the ZOE 70 was in individuals that were 70 years of age and older. So then they pulled the analysis of that, and they could see that there was vaccine efficacy of around about 91.3% against herpes zoster. No safety concerns at all. It is slightly more reactogenic than the placebo that was used in the trial. Injection site reactions were around about 81.5% versus the placebo group that were 11.9%. Systemic reactions in the Shingrix group were 66% versus sort of 29.5% in the placebo group. So definitely it is a safe vaccine, and as you can see, extremely effective vaccine. So if we look at ZOSTAVAX safety, definitely people will experience some, or most likely experience some post-injection discomfort, whether that's headache, fatigue, etc. But it's generally well tolerated. Usual vaccine type side effects, realistically. So they should resolve. If they don't resolve in a few days, then they should be reported as a reportable adverse event, because there shouldn't be anything untoward. So while that risk is really small around transmission of varicella zoster virus from the fluid in the blisters to someone who is perhaps either immune compromised or has never had chickenpox, then yeah, definitely we would want that rash covered. So can ZOSTAVAX be given on the same day as other vaccines? Yes, absolutely. All live and inactivated vaccines, they can be given on the same day as other live virus vaccines, but of course, if being a live virus vaccine itself, if it's not given on the same day, then you need to follow the general rule, and that's separate administration of those live virus vaccines by 4 weeks. Obviously, we don't need to worry so much with Shingrix because it's not a live virus vaccine, so that can be given at any time in relation to a live virus vaccine or any other inactivated vaccine as well. There is a little bit of guidance from ATAGI that does say that it is acceptable to co-administer Shingrix and Fluad Quad, so that over 65-year-old flu vaccine on the same day if necessary, because we do want to optimise vaccine uptake, and we do want to take opportunity to vaccinate people when they are in front of us. So there is that consideration. If you know your patient really well and they're happy to come back a few days later, then you can separate the Shingrix and the Fluad Quad administration. So it's just something that you can work out really with your patient, but you know, saves time and energy if you vaccinate them on the same day. So with Shingrix, no safety concerns at all. Generally, those common injection site reactions were a little bit higher, like I said, and just the usual systemic reactions that we see with most other vaccines. So really nothing to be overly aware of. I had a bit of a red sore arm, nothing over the top at all, just a little bit more reactogenic than any other vaccine that I've received, but other than that, I felt fine. So, okay, so we want to optimise uptake. I'll skip through these nice and quickly, but definitely recall patients, particularly those that are in the catch-up program at the moment. Keep raising the idea of having ZOSTER vaccine whenever you see your patients, and particularly once people do turn 50 and they might be coming in to have a tetanus booster or a DTP booster. Mention it to grandparents when they're coming in for their DTP boosters. Mention it at flu season. Mention it when you're giving your pneumococcal vaccines. Just keep it on the front burner because we just want to reduce people's likelihood. Like I said, we will talk about some antivirals. We know that they play a role in reducing the severity of zoster disease, but they don't really impact on the severity of the PHN, so that post-herpetic neuralgia. So once again, it comes back to prevention is better than the cure, so take every opportunity to get this vaccine. Antiviral treatments, your famciclovir, your valacyclovir, acyclovirs may help reduce pain and shorten the duration time, but treatment really is best taken within 72 hours of the onset of that rash. It might be helpful if it starts later. However, there is high quality evidence that oral acyclovir does not reduce the incidence of post-herpetic neuralgia significantly. So treating pain associated with herpes zoster, particularly in that acute stage, is considered an integral component of management and may have benefits in reducing that severity and incidence of post-herpetic neuralgia. And controlling PHN can be really, really difficult and complex. Many patients are not satisfied with the effectiveness of pain relief that they have been prescribed. And sometimes you may need to refer these people off to specialist pain clinics in order to better manage them. So just to conclude, we do know that herpes zoster does increase as the population ages. We're going to all be at risk the older we get. Doesn't matter how healthy we are, whether we exercise every day, whether we are vegan, whether we're not, whether we eat healthy, whether we don't, it doesn't matter. This certainly can happen to anybody as we get older. It really is age. So early management as much as we can for antivirals, analgesia to reduce the pain. It's they're expensive vaccines, so get those patients eligible for zoster to come back in and just keep asking them about having a shingles vaccine.
Very good advice. Thanks, Angela. Now, I am cognizant of the time. We've hit the 1 hour mark, but I will ask you these questions. So those who'd like to get some answers to some of the questions in the Q&A box, you can stick around and we'll see if we can get through them nice and quickly for you. So Atusa has asked, if an elderly at greater than 60 has no measurable antibody to HZV, what vaccine would you advise?
Then there is some guidance in the immunisation handbook around whether or not you should or shouldn't give shingles vaccine. But in that case, if there's no antibodies, it means that she has never had chickenpox, so should be vaccinated against chickenpox, and it would be a 2-dose schedule given her age.
Beautiful. Thank you. If you've received varicella vaccine at 18 months, will this prevent you from getting the shingles, says Maria?
Oh, good. That's a really good question. Look, it is a live virus vaccine that we're giving. There is some evidence coming from countries where they've used these vaccines for much, much longer than Australia. Shingles cases can still occur in people that have received chickenpox vaccine. And we've got to remember that chickenpox vaccine is not 100% effective. So it's not going to stop somebody getting chickenpox in their lifetime. It's going to reduce their likelihood. So yes, they still are at risk potentially of having shingles down the track.
Great, thank you. Amanda, are some patients more at risk of stroke than others post shingles?
Look, I've not seen any specific data around that, to be really quite honest. It's, when we sort of talk about the risk of stroke following infections like shingles, it really is around that inflammatory process and whether they have got plaque. So if you've got somebody who's quite that's got high cholesterol or something like that, where you know that they've probably got a heap of plaque around, then yeah, they probably will have a higher risk.
Okay, great. Thank you. Now, Peter just wants a little bit of clarity on booster for ZOSTER. He's heard of someone who has previously been immunised and subsequently developed shingles, and just wants a bit of clarity there, if you wouldn't mind.
Absolutely. So if they've been immunised with a shingles vaccine, obviously, if that was ZOSTAVAX, for example, we could see the data there quite clearly that it's around about only 51% protective against developing shingles. So absolutely, it could happen that you've been vaccinated and you could still develop shingles. There is obviously going to be, your own cell-mediated immune response from having the disease. There's no indication at this stage to be giving them another shingles vaccine. However, someone that's had ZOSTAVAX vaccine that wants to have Shingrix vaccine certainly can wait 12 months, though, from that previous shingles vaccine, that ZOSTAVAX vaccine, or 12 months from the disease.
Okay, now Atusa is asking about reaction to Shingrix. She's had a patient with extreme tiredness and shortness of breath post Shingrix. Would a second dose be recommended, or should it be omitted on that occasion?
Look, if it wasn't an anaphylactic reaction, then I would be definitely going ahead with the second dose. You might like to keep her a little bit longer in your waiting room or observe her for a little bit longer. But, that type of response doesn't really meet the criteria for anaphylaxis. So you'd need a little bit more information about what the shortness of breath was and how long did it last, etc.
Okay. How long after Shingrix can one have a COVID booster?
Yeah. After Shingrix, there's no time frame really at all. Atagi is sort of saying, look, there's limited data around Shingrix and other vaccines. So you could, wait a week, go ahead and have your booster then.
Yep. Patient 80 plus years old, should they have ZOSTAVAX or Shingrix?
Oh, entirely up to the patient's choice. They're not funded for either of them. And a lot of 80 plus year olds now are scooting around and they really are loving life. So we want to keep them loving life and keeping them free from shingles. So it would really, really be their choice on that.
Would you recommend redosing someone after a bone marrow transplant, either autologous or allogeneic?
Yes, absolutely, 100%. They will be managed, those sorts of patients will be managed by obviously the haematology team. Vaccination does not recommence for those patients until at least 6 months post-transplant. And certainly I had heard along the line that there is a hospital in Melbourne that's added Shingrix to its post-transplant vaccination list. I don't think that that's common everywhere. But personally, my husband's just had a stem cell transplant, and by heavens to Betsy, he'll be getting 2 doses of Shingrix as soon as we can get it into him.
Very good plan. Have there been any studies from Atusa reproductive effect of Shingrix and COVID infection? Do you know of any studies about COVID and Shingrix?
As in people having...
I assume she's saying having had it, and does it have any effect on COVID, or which we would assume not. But yeah. I'm not...
I mean, look, certainly they are 2 different diseases, and certainly, somebody that's had COVID, we have been seeing an increase in shingles rates, but they can certainly the vaccine can't,
yeah,
make them more vulnerable to COVID or anything.
If that didn't answer your question, if you could just reword it slightly and we might be able to readdress it. Marjorie said that a GSK rep told her ZOSTAVAX only lasts 4 years. Is that the case according to your knowledge?
Yeah, look, there is decline around about the 4-year mark, and the ATAGI documents would say that it declines significantly in the 5 to 10 years post-vaccination. So it's something that is being really closely monitored, because there's just not enough data really at the moment to sort of really piece together how long, whether or not there is still going to be protection there, even though antibody levels aren't seen. A little bit like hepatitis B. You know, we can still have protection, but we don't see antibodies yet.
Okay. Alison's just popped in a statement that she works in an ED and doctors often recommend anaesthetic gel to patients for pain relief. Do you know if that's effective? What do you know about that?
Oh, look, if people are really nervous about it all, anaesthetic gels are okay to put on the skin prior to vaccination, but they've got to be put on the right area for the right amount of time. They do need to be wiped off completely before the vaccine is administered. So you would use it very much on a case-by-case basis. It wouldn't be something you'd do routinely.
I'm not sure if she means on the lesions or on the vaccine site.
Right, okay.
Yeah.
Yeah, there are some topical meds that they do prescribe for the pain. So,
side effects more likely after the second dose of Shingrix? Same.
Yeah, marginally or same. Yes, not specifically, but some people do.
Yeah, and Alison has written in that she meant for the PHN pain, not for the...
Oh, yeah. Look, or I don't know that anaesthetic gels would do much for the PHN because it's just that real neuropathic nerve pain. It's not, I mean, anaesthetic gels are going to work well on skin, but yeah, they're not going to get too far from that.
Yeah. Any issues with immunising over 80s from Leon? And we can just briefly cover that one off.
Yeah, no, go ahead. If they want one, yep, absolutely, go for it.
One from Atuza, and thank you so much, everybody, for your engagement and questions. It's been great. If a patient misses a second dose of Shingrix, what's the schedule in terms of should they get a second or just, sorry, another 2 doses or just another single?
Yeah, look, the advice at the moment is if someone does not return at the 6-month mark, then to contact the medical team at GSK to seek further advice about that.
All right. Great. Thank you very much, Angela. And we'll finish up there. It's been so great to have you involved once again in our webinar series this year. And we thank you immensely for giving your time and expertise. So wonderful to and engaging to watch. So that completes our series. I've popped in the chat that you can now register for our annual scientific meeting occurring on the 5th and 6th of February. So we'll be getting the program out. It's a fantastic program for next year's event. So we'll be getting that on the website very soon. And you can now start registering for the event virtually. It's free registration, of course. Angela's slides and the recording will be available on the website next week. And please, if you get time, fill out the short survey after you close your Zoom. You'll be sent the link, or it'll pop up in your browser there. And we'd love to hear from you and whether we've met your needs today. So if you've attended for more than 50 minutes, you'll automatically get a certificate for the event. You don't need to email for that. So thank you once again, Angela. Thank you to the immunisation.
Thank you, Susie.
And thank you so much for our engaged audience tonight. And we wish you a happy and safe November and holiday period.
Thank you, everyone, for joining. Hope you found it interesting. Stay safe.